My name is Nathan Wong from the University of California, Irvine, where I direct the heart disease prevention program, and I'm also the immediate past president of the American Society for Preventive Cardiology. I'm here at the World Congress of Heart Disease to talk about screening of atherosclerosis in metabolic syndrome and diabetes. I think, as most of us know, the evaluation of cardiovascular risk is a very difficult task, and we know that many individuals who perhaps have borderline risk factors, we come across a large number of such individuals who eventually suffer coronary heart disease events, and in fact their calculated risk, if you use something like the Framingham risk score, is oftentimes very low. For example, someone who has perhaps borderline obesity, who is pre-hypertensive and perhaps has impaired fasting glucose and has low HDL cholesterol, such an individual may only exhibit, for example, a 3% 10-year risk of coronary heart disease, but may actually be at as much as a 40% lifetime risk. So we really need better modalities to assess someone's long-term risk of cardiovascular disease. One of these ways to better evaluate risk is to screen for atherosclerosis using certain modalities such as carotid B-mode ultrasound, perhaps also coronary calcium screening, or actually ankle-brachial index. Some work that we've done with the multi-ethnic study of atherosclerosis and actually published in actually diabetes care with my associate, Dr. Shaista Malik at UC Irvine, who was the first author of this study, shows that among individuals who have metabolic syndrome and diabetes, if they actually have very low levels of coronary calcium, such as scores of less than 100, they are actually, their risk of coronary heart disease over the next 10 years is actually as low as many individuals who do not have these conditions. So there's actually a very wide range of risk that we see in persons who have metabolic syndrome and diabetes, which may range from as little as 1% risk in the next 10 years to perhaps 20 to 30% risk, and is highly dependent on the amount of subclinical atherosclerosis present. So in fact, recent guidelines by the American Heart Association and American College of Cardiology actually give a Class 2A level of evidence B recommendation for coronary calcium screening in persons who have diabetes, because it is felt that such screening may enhance our ability to identify those who are at highest risk and perhaps need the most aggressive intervention. So that's pretty much what I'll be talking about, as well as some of the other screening modalities and how they fit within the evidence-based recommendations for cardiovascular risk assessment in asymptomatic individuals.